Hi, and welcome to this solo episode with me where I dive on into how to prepare for a natural hospital birth. I know that there's many women out there who really want to have a natural birth and who either just feels safest choosing a hospital, maybe for her first, or there's just no other option in your area. Maybe there are no home birth midwives, maybe there are no birth centers. Maybe the only option you have, if you want to have a care provider at your birth, is to have a hospital birth. And so this episode is here for you to help you truly optimize your chances of having a natural, positive, empowering birth experience for yourself and for your baby, and the best start in life for your whole family, really together. And, I want to preface that I truly believe, and research tells us that if you want to have a natural birth, then your best chance at having that and the highest satisfaction amongst women is midwifery led home birth care. So, home birth. And the second choice is birth center. Um, but that's not where we're going to go today. I will do a separate solo episode on home birth and how to optimize your chances of having your best home birth to prepare for home birth. This is going to focus on natural hospital birth preparations. So, if you're one of these women who want to have a natural hospital birth, then please listen to the entirety of this episode. I'm going to go into depth and detail, and you really do want to listen all the way through to get the most out of it and to be able to prepare for your hospital birth. So, first and foremost, as I've mentioned in a previous solo episode where I tell you how to prepare for a natural birth in any birth setting, and I really, really encourage you to listen to this one. I start by saying that it is so important where you birth and with whom for your outcome. Where you birth, their philosophy around birth and the care providers that you have around you will greatly influence your experience. So, if you're choosing a hospital birth, please do your research. This is so important. And choose the hospital that has the lowest intervention rates, the lowest cesarean rates, the lowest induction, epidural, NICU admission for your baby. All these rates, let them be low. Compare the different hospitals in your area and choose the one that has the best stats. So, which means the lowest when it comes to interventions and medicalization and cesarean rates. And if you do this, you'll notice that there is a big difference between different hospitals and care providers. Secondly, choose to birth with midwives. That is going to give you the best chance. Across the board, whether it is at home, birth center, and hospital, midwives has the best rates when it comes to natural birth success rates. So, and it makes sense because if you think about it, a midwife, obviously, trainings look different around the world, and there's better towards woman-centered and kind of normal birth education for midwives compared to some that are very much groomed into being obstetric nurses and very much in the medicalized area of birth. So, it doesn't mean that a midwife will necessarily be great at providing care that really optimizes your physiology and having a natural birth, but it's a greater chance than if you're employing an obstetrician. because obstetricians, whether they say that they're pro natural birth or not, they're great at being surgeons. They're great at cesarean sections. They're great at medicalized birth and pathology because that is their expertise. That's where they did, their studies towards. They have not seen fully physiological birth. I think almost no obstetrician, very, very few obstetricians have seen a woman giving birth truly optimized in her physiology naturally without any intervention because their schooling is towards the pathology of birth, labor and birth. And also that's when they're called in. If they're not the primary caregiver, if you don't employ them, then they will be called in by midwives when something does deviate from the normal, when something is pathologized. So they only see that. That's what they're primed in their minds at seeing. And also then their outcomes, even when they're caring for women who want to have a natural birth, their outcomes are usually worse, and much more prone to medicalization, interventions, cesareans, than if you go with midwifery-led care primary. So, if you want to have a natural birth, do not employ a surgeon, employ a midwife. And then, of course, there's different ways, of course, to birth in a hospital. You can choose to have a private, independent midwife. That is your absolute best choice because her allegiance lies with you. You are her employer. If you choose to go with the publicly funded midwives, then their employer is the hospital. And so that will be where they need to follow the guidance of their employer first and foremost, and your wishes second. Now, I'm not saying that they're not amazing midwives within the system who will bend the rules and try their absolute best to provide the best care for you and withhold maybe even information about how dilated you are and so on and so forth to protect you, which is what a lot of midwives do in the system. They try their best to protect you from the system that they're working in because it is very, you're walking into, if you're birthing in a hospital, in a system that is not set up for women, babies, for natural birth processes, for families. They're very much geared towards medicalization of birth, and it's spinning out of control at this moment. It's getting actually worse and worse. So that's why you really need to know how to prepare yourself to optimize your chances of having a natural birth there. Because it's not going to be easy. And I really want you to know that. I'm not going to fool you and say that yes, you can walk into a hospital and have a natural birth. You need to do a lot of preparation. You need to do a lot of research. You have to choose wisely. And I'm going to give you all those tips in this episode. So do your research about who you're employing, because essentially, even though you're walking into publicly funded hospital birth, it is your tax dollar um, money, so you are the customer. And that's really important to have that mindset as you walk into the hospital or maternity care during your pregnancy, that you remember that you're actually employing this person. They're working for you. Even if you are getting publicly funded um, uh, birth, or maybe it's through your insurance, whether you are, wherever you are in the world, they're still working for you. Because this power dynamic is often the opposite. As we walk into the doctor's office or the midwife's office or coming into hospital, we are so deeply primed in our subconscious mind of this hierarchy of you them being the patient, not the customer, that you are looking to them as they're the experts. And this is so ingrained in us. We didn't, I really encourage you to do a lot of work with this. This is something that me too, like I'm a midwife, right? I'm a former midwife. I have worked in the system, and still when I go as a private person to the doctor or, to the hospital, whatever, I feel this dynamic. right? And I need to claim that I am the customer here and not the patient, not the, underneath, I am the expert of me and I'm a sovereign human being. And it's so important to claim this, especially if you're wanting to have a natural birth in a system that does not support that. You need to be even stronger in your sovereignty, in your conviction of what you want and who you are, in trusting yourself, in having a relationship with your body wisdom, intuition, just trusting yourself and your voice. And so, yes, so choosing wisely to the best of your ability, the hospital with the best statistics, and if you can have an independent midwife with you, that is your best chance because he'll be working for you. And if you can't, choose midwifery-led care where they are the primary caregivers unless you become high risk, quote unquote. And that is truly how you are going to be viewed in the system. You start out as low risk. It's in the language here, low risk. So they see you as risky. Even if you're healthy, you've had a healthy pregnancy, you have a healthy baby on board, you're a normal woman carrying a normal pregnancy, you're still risky. You're low risk. And at any moment, you can become high risk. And so this is how you are kind of viewed and seen. So when you prepare for a natural hospital birth, you need to know the system you're walking into so that you're fully informed as you come in. So, what I would recommend is that you already, as you attend antenatal appointments, really state that you are going to have a natural birth within the hospital and that you want that in your notes. You want them to write notes and you want to see the notes that they're writing. And you want to already in pregnancy start to share with them what you're going to accept and decline when you come into labor, into the birth suites and when you're in labor and going to birth your baby. So I have an ebook, a free ebook that I'm going to put down below in the show notes for you to download. And I'm going to go through that with you now. And then you can download it and you can use it when you write your birth plan. And I want you to discuss this with the midwives that you're seeing throughout, or, your doctor, if that's how you're being cared for throughout your pregnancy, so that you're priming them, because that's what happens at antenatal appointments. They're kind of wanting to inform you about things, but they really want you to take a certain path, mostly. Again, there's beautiful midwives and doctors who really give you all the benefits and the risk and the alternatives with everything that they're offering. They're really giving you good information, but mostly it's a very short session of maybe 15 minutes. For some, it's even less. You come in, they take your blood pressure, they measure your belly, they listen to the heart rate, they check that you're not sick, they might do some blood tests or urine tests or other tests, and they kind of give you pamphlets to read about all the things in pregnancy you have to make a decision about. And then they start doing the same thing. They start to prime you towards having a hospital birth and kind of all their routines and all the things they want to do to you as you come into the birth suites. And they kind of prime you to be a compliant patient, truly. They want you to be a compliant patient and say yes to everything that they will offer in your labor and birth process. And so I want you to beat them to this. I want you to download my ebook. I want you to read through it and now go through it with me. And already, as they start talking to you about these things, or maybe they don't, then you bring it to them and you want it in your notes that you've talked about it. You want it in your notes that this is what I'm going to accept and decline. And I want a natural birth. You can even state that throughout your appointments that, as you come in, if you go into the hospital, you most likely don't know who's going to care for you if you have not chosen a private midwife. Then you're going to come in, and whoever is on shift that day will care for you. So state even in your appointments that you want it in your notes that you want someone that maybe is a home birth midwife or someone that is comfortable with natural birth, with unmedicated births, someone that is comfortable with um, and understand physiology, like say all these things and make sure that you want them to put that in your notes, because as you come in to the hospital to birth, you will definitely want to have your um, birth plan, but they will also go through your notes and look at how has your pregnancy been, is there anything here flagged, whatever. And so if there's been a lot of talk about this, they realize how convicted you are in having your natural birth, right? And so they could also be, hopefully, that when they come on their shift, someone that is comfortable with a natural birthing woman, someone who has seen that before. Because again, actually, a lot of midwives, doctors in hospital might never have seen a natural birth, very few. In some places, it's very like none. So, and in some places, absolutely. So I'm not saying all hospitals are like this, and it's so different around the world and in different areas of a country and so on and so forth. But depending on where you birth, maybe no one in that hospital actually has really fully seen a woman decline most things and have a natural birth, right? So and maybe they have. And so then the midwife who feels most comfortable can say, I can take her. And you want that kind of midwife. You want a midwife who chooses you and not someone who gets kind of put with you, who's actually really scared of birth and who has a really high cesarean rate, or, who always has postpartum hemorrhages because she's so scared of birth that she makes it kind of happen through her interventions and disturbances and so on and so forth. So talk about this throughout your appointments with your care provider in pregnancy, and definitely write a birth plan. Now, there's a lot of ridicule around that. Maybe by your care provider saying like, oh, make birth wishes because we don't know. And like have a birth plan. Have a birth plan, and then of course, you can change your mind about things. And things can happen. And then we take it from there. I mean, I usually work with my clients that they have a birth plan and then they have a birth plan B. Like, so in case of this, then I choose this. It depends also who you are as a woman. If you have this need for control, which if you're choosing a hospital birth out of the idea that it's the safest place to birth, even though actually if you're a healthy low risk woman, quote unquote. I'm using that word that I don't like. But if you are a healthy woman, have a healthy pregnancy and baby on board, then actually the safest place to birth is actually your home with home birth midwives. It's just the research, it's the stats, it's the truth. So if you're still choosing to birth in the hospital, then you really need to have a kick-ass birth plan to protect you and your space within that. So let me go through my ebook with you and kind of talk about how to make your birth plan and kind of how things that you might not think disturb physiology do. Essentially, I want to start with, before I go through this, that policies and guidelines in hospitals, most of them actually are not evidence-based. The obstetric field is very emotional based. A lot of and I love that there's some beautiful midwives and researchers out there who have debunked so much of these, that actually when you go through and look, like, where does this policy or guideline come from? And you go like, oh, it comes from this paper and this paper and this paper, whatever. And as you follow it through, it just comes from generally men back in the day who decided that this anecdotally was safest to do. So it's not based in evidence. It's very much in maternity care that a lot of things that are unevidence based that is being practiced because a lot of doctors have felt this way about it. Fear of things have created these policies, but they're actually not helping. And you might be shocked by this. It is shocking that it keeps on being this way, and that you, as the consumer, so as the pregnant woman, need to do your own research and like kind of find the truth around things. Fortunately, we're getting more and more of this debunking and research by amazing midwives like Dr. Rachel Reed and Sarah Wickham, for example. And if you're curious to learn more, then these are two midwives I would highly recommend you to look up and learn from. Um, Anyways, I want to preface that. So, as I said before, you're seen as low risk if you are that. I mean, you could be high risk already and be in hospital for that you couldn't find a midwife to assist you because you're high risk and she's not quote unquote allowed to care for you. Of course, there are midwives who still do, and God bless them, because they are literally putting their livelihood and maybe even their life on the line in a sense of life, in a sense that they could get put in jail in some places for caring for women that are seen as then high risk. So midwives who do, I mean, again, this is so different around the world. Some countries are, harsher than others. In some areas, a midwife can care for high risk women, and that's fine. So it depends where you are, but it's definitely a witch hunt on these midwives. So do know that like these home birth midwives are rebel kick-ass. They have a strong belief in what they're doing and they want to serve women first. But it's also actually quite dangerous to be one. Um, Anyways, so these routines that is done in the hospital is done because there's this assumption that you at any point, you very risky woman, could go from low risk to high risk. And so in most places around the world, you're screened as you come in labor, even though you might just almost be popping out a baby. You're still going to have midwives and nurses who wants to do all these things to you. They want to palpate your belly. They might want to put a CTG on your belly. They might want to do observations like blood pressure, taking your pulse, your temperature. They might want to take urine and blood test and put an IV cannula in your hand and do vaginal examinations, all directly when you come in without observing you, which happens in birth centers and at home. It's much more kind of the midwife observes and can see through sounds, through behavior, through smells, through just how the way the woman acts, through the purple line in the back above her butt crack. There's so many ways that you can see where a woman is at, and these midwives in birth centers and home birth settings don't view you like a potential risk that's going to just like blow up, which essentially is the vibe in many places in hospitals. Now, again, there's some hospitals that are not like this. There's some midwives that, greet that woman gently, put her in the room, allows her to settle in, observes her, and then gently asks to do these observations and, is open for you to declining. Again, you don't know who you're going to have with you in your labor birth process and how they will accept or not your birth plan and your wishes and your desires. When you come in labor, the reason they want to do all these things, well, first and foremost, they want to do a vaginal examination very quickly because they want to determine if you're actually in labor or not. Because you, silly woman, don't know. Yes, I said that. You, silly woman, don't know. I mean, that's really the idea, is that women just are so oblivious. They need someone to put their fingers in their vagina and check their dilatation to tell them where they're at. And if you've listened to this podcast for any length of time, you know that birth is not linear and that actually dilatation tells us very little. Um, and this routine of checking your dilatation is also kind of a way to protect you, funnily enough, because you're sent home if you are, and this is also, again, it's so different around the world now. Anywhere you'll be admitted in spontaneous natural labor if you're anywhere from 3 to 6 centimeters. So that's very different. Which country, which hospital, state, what that hospital's kind of policy is when they will admit you. So if you're anywhere between these centimeters, they will go, okay, you can stay. Or, no, you're too early. You need to go home and come back when you're further along. So they're kind of gatekeeping in one sense because they want to protect you, because the longer you are in hospital, the bigger chance you have of interventions, meddling, medicalization, and risk of cesarean section, to be honest. So it's a way of protecting you, but it's also because you're taking up room. It's kind of a factory in the hospital. They take in women. They need to birth in a certain amount of time because they're taking up space and resources. They need to be shoved off, to the postpartum ward, and then new women can come in and. So it goes both ways. It's a way to protect the woman against medicalization, but it's also a way to, have room for the ones that are going to birth quicker. Now, of course, you can be a woman that births really quickly and you can go from 2 centimeters to 10 within just a few hours, or even quicker. I mean, there's women that birth super fast. Most first-time mamas do take a little bit longer, and that's kind of where this generalization of thinking comes from, that, oh, she's going to take a longer time. If she's only, quote unquote, 2 centimeters, then she's probably going to be at least 10 more hours or maybe even more than that. Before she has the baby, most likely. So if you, this is kind of how it works in birth centers too. If you do a home birth, however, most home birth midwives would not. Again, this is also depending on who you choose and if they are publicly funded or if they're independent. Especially independent, you might not have a vaginal examination your whole labor and birth. You don't need one to birth a baby. But you're choosing a hospitable birth, and so this will be something that if you're not about to have a baby, it's going to be hard to decline. You can decline it, absolutely. And it's easier, obviously, if you come in and you're very close to having a baby, which is definitely preferable. If you want to have a natural birth, you want to get into the hospital as late as possible, preferably pushing to not have any kind of interventions done to you. But if you come in earlier, which most women do, because at the end of the day, also to go from the early labor phase into kind of established active phase of the labor and birth process. When you're in the early can take a long time. It can also stop and start until you're in the active. This is like the terms that the medical establishment uses, right? So that's why I'm using it here, because you're going to have a hospital birth. So let's talk these terms. This active phase is when you kind of have regular contractions and they don't change from kind of that regularity. They're not going to stop, essentially. They're going to continue until you have a baby. That's when the hospital wants you to come into the hospital. They don't want you to come in too early because things can slow down. You can have these, and the thing is, you can actually have plateaus in active labor too, of like slowing down, natural pauses, all of this. But generally, it's more so in the early phase where you can have a few hours of what it looks like ramping up, and then you can have a long pause of hours, maybe half a day, and they can come back. And I mean, this prodromal labor is a thing. Anyway, I'm deviating. So that's kind of where the checking where you're at comes from when you go into the hospital. So, oh no, that's what I was going to say. A lot of women, well, every woman really is like most women. When you are in that early, trying to establish phase, your body's trying to establish in active labor, it helps to be in the place where you feel the most safe. And if you've chosen to be in the hospital, then you're actually going to want to go in because that's where you feel the most safe. You've chosen that place because of that. And then they're gatekeeping going, it doesn't matter that you feel most safe here and that you've chosen this for your birthplace. You're only this far along and you're just still early, so you need to go home. And then women might stay in this early labor phase for much longer than they would had they just been admitted to their place where they're going to birth, because it's so primal. We want to be where we're going to birth. That's what the early phase is about. It's about getting yourself ready to go into the birth bubble, the active phase where you're kind of, going into, especially if you're doing a natural birth and you're having a longer labor where you have the time for the hormones to build and you go into this trans-like state and you go into it's more vulnerable to be there in between worlds opening up, in this real powerful portal. So when you're in the early hours, in that early phase still, that is when you're supposed to find your safe place. So no wonder so many women going to hospital, quote unquote, too early. It's because they're they're primed for that. It's primal. You're supposed to find your safe place to birth. And so many women will go into hospital 3 times, 2, 3 times before they're admitted because they're coming in, quote unquote, too early. It's not too early, though. It's very natural to do that. And it's so devastating for them to then be like sent home. And maybe they have even an hour of driving and they keep, going in the car. And all of this, of course, disturbs the physiology of birth. Like, obviously. You need to feel safe, unobserved, not moving in a car, not being in traffic, not being on your way to something. Of course, you're going to slow your labor down. It's so obvious. It's so logical. It's such a messed up system. But because the hospital works like a factory and they don't have places for you to be in early labor there, you're supposed to be in active labor, unless you're being induced, because then you can be there for 3 days and they try to induce you for several days. I mean, also, so not logical. Anyways, now we're talking about natural hospital birth. Anna, don't deviate. I will not. Okay, come back to what you want to say. So I just wanted to say that because there is a big chance that you go in, quote unquote, too early. You really want to stay at home as long as possible if you want to have a natural birth. And I mean, through all of this, I really want to emphasize that you should not go into hospital and want to have a natural birth. Well, you shouldn't go into hospital, period, without a doula or a sacred birth worker. Like, that is just a massive, like, no, you don't. You need someone with you that you've employed. If you don't have your independent midwife in your hospital that you've employed, that you trust, that you've talked about all these things about, how you want to have a natural birth, and she's fully on board with that, that's her jam, she loves that, she provides that, she's into physiology, If you don't have that midwife, with most of you will not have, you will go into hospital just getting anyone on shift. You want to employ someone that walks in with you, a kick-ass birth worker who knows physiology, who can advocate for you, who can be a rebel advocate in there, protect your space, protect your wishes, take that confrontation outside of the room with the midwives or doctors who want other things to have your birth plan and fight for you outside of the room where you don't even have to hear it or engage in that, and you can just birth your baby in peace. So I work with women like that who wants to have a hospital birth or needs to because they do have some medical stuff going on that actually it makes it safest for them to be in the hospital. But they want to have a natural birth within that setting. So you want to have this person with you. You don't want to go into the hospital and advocate for yourself. That is totally going to take you out of your physiology. It's going to disturb your process. It's going to make it much harder to have that natural birth. And you don't want that. You don't want to have to fight in labor. That should not be your role. And you don't want to put that pressure on your partner. Because I hear this a lot that, it's just going to be me and my partner, and he's going to hold space for me. Okay, so my jaw is like dropped here. Um, I think that is not fair, actually, because he has never seen a birth before. He's not educated in this. You're probably more educated than him. And to put that pressure on him, and how will he be able to know? How will he be able to know how to advocate for you? And if someone, and to be honest, a lot of the language within the hospital, there's a lot of coercive language. There's definitely dead baby card, thrown around. I'm just being honest here. It's not a scare tactic. It's just the reality. Again, you might be lucky. You might get an amazing midwife, an amazing doctor who doesn't do this to you, but the majority will. And so let's talk about the majority and let's hope for the exception that you get just the most amazing people that's going to care for you. Let's hope for that. Let's prepare for that and wish for that, but also let's prepare for also that most likely there'll be some people there that are not like that. And you could also get someone that's really, really not very nice. So you want someone who's on your side, who's going to allow you and your partner to be in your birth bubble mostly, and that she can mediate, navigate, advocate, protect, and support you in having your natural birth. And whether you're having a natural birth or not, if you go into hospital, you should not go in just with your partner. I don't think that that's wise. So let's go back to the routines. So let me tell you about them. So when you come in, either you go to triage, which is how it happens in America, for example, or you go into the birth suites, and it's kind of the same thing. They check you out with measurements. So they will palpate your belly, feeling where the baby's lying. You're lying on your back for this. They're feeling for the head. They might or might not put a CTG on, so a continuous monitoring of your baby's heart rate and the contractions. And they will take your pulse, your blood pressure, your temperature for a baseline to see if you're going to pop up and be high risk at any point. Then they have the baseline of where you're at when you come in. They're gonna want to potentially take a urine sample. Many places want to prophylactically put in an IV cannula in your hand in case you're going to get medication, if you're going to be all of a sudden in an emergency, or if you're going to need a cesarean, then they've already done that. So, it's again assuming that you at any point will blow up and become high risk. That's just how they work. So let's talk a bit about this. So even something as simple as when you come in, that they want to put you on your back to palpate your tummy is going to, especially if you're in really active labor, it's going to be painful and uncomfortable to lie on your back. It's, as you know, one of the worst things to do. And so even this seemingly simple thing, it's actually disturbing your process. It's taking you out of potentially your birth bubble, which then brings you out of potentially your coping mechanism of breathing or being with. And that increases your pain perception. And it might really, actually, that simple thing of just palpating your belly might take you out of your zone and into a spiral of pain, tension, kind of cycle, fear cycle. So that is a risk. It's a risk, even that simple thing that they do. The observations, again, someone blowing up a blood pressure cuff, or even those things of like strapping you up to things. Also, it disturbs you. It disturbs your process. And so generally when you become disturbed in your physiology, then it might much so be very hard to get back into your flow. If you had the flow when you got in there, they might take you out of it because they're talking to you and they're poking and prodding you to do all these baseline things. And not to talk about like putting in IV cannula in your hand. It's one of the most sensitive areas, our hands. And they want to put in I mean, it's a plastic tube, but it's with a needle first, right? That hurts. And for some women, it goes really easy, but for some, it takes several goes to get that in. And that definitely disturbs your physiology. And if you're low risk, which is the term, if you're just healthy and normal, then you don't need that. I mean, even if you're high risk, I'll be like, well, put it in if it turns out that I need this for some reason, which is IV fluids or easy access medication. But you're in a hospital. If something happens, they can press a button and there'll be 10 people or more running in and doing all the things that needs to be done. So why would you prophylactically, especially if you're healthy and have a quote unquote low risk pregnancy, need that? I would really question that for you to do. And so when they do that, they usually take the bloods, which is very common to do in the hospital, even though you might have given blood most likely throughout your pregnancy, and they know your blood type and they know other things about you and you know what you're immune to and not, and rah de rah. A lot of the times, if they put in a cannula, they just also take blood. But there's absolutely no benefit, I think, to putting in IV cannula. Only risk that, you know, you have this thing on your hand, it creates pain. That extra stress and uncomfortable feeling will most likely, you know, also affect your your labor and birth process. As we know, as women, we're so delicate in the sense of our hormones, and if we are a highly sensitive being, which a lot of women are, then all this poking and prodding really does disturb our process and makes labor potentially longer, more painful, or just these pauses and stalling in the process. And then we have the vaginal examination. And unless you're about to have a baby when you come in, it's going to be hard to keep them at bay of wanting to do an admission vaginal examination. Absolutely, you can advocate for this. Again, with absolutely everything I'm going through, even the lying down and palpating the tummy, all the things. I mean, you can literally walk into hospital and just decline everything. Of course you can. I mean, that's going to be a big fight, but of course you can. And especially if you have a sacred birth advocate with you, of course, you can say no to everything. It's totally up to you. Your body, your choice, your baby, your process. It's going to be harder for them to decline you access if you're about to have a baby. If you are earlier on in your labor and birth process, you know, I definitely had women who just are very firm in that they do not want vaginal examinations and that they accept that. More so though when you're closer to having a baby. So it depends where you end up, you know, what hospital, and will they just send you home or will they keep you in triage until you're about to have a baby? I don't know. That's a gamble, I guess. But it's definitely just no benefit with routine vaginal examinations. So if you're going into hospital and you've decided to be there, then an admission vaginal examination might be something that you decide that you will do to be admitted, and then you decline everything else after that, all the vaginal examinations after that. Usually the routine is to do a vaginal examination every 2 to 4 hours, depending on where you birth in the world. Some places do it even more so, every hour. So this is the usual one, 2 to 4 hours to check the progress to see how you're dilating, because it's still somehow believed, even though we have debunked that so much through research, that you're supposed to open like a centimeter an hour, half a centimeter an hour, again, so depending on where you're at and what they kind of want to see you do. So there's no benefit really to do a vaginal examination on routine. The only kind of benefit would be if it looks like you're deviating from the normal physiology, that you spike a temperature, you're sick, there's an emergency situation or something, then seeing where you're at makes sense, but not on routine, not when you're just laboring like a normal woman laboring. The risk is obviously that it's uncomfortable and painful. There is increased risk of infection every time someone puts their fingers, even if they're gloved, up into your vagina. There's a risk of um, the waters breaking when someone does a vaginal examination. And when the waters break, you have a whole other, set of risks that, it increases infection, and it can stress the baby. You can get a much kind of more intense labor after that. And when the waters break, there's definitely the cord prolapse. If the waters break and the head is not engaged, then that can happen. I mean, it's a very tiny risk, but it's still there. And so it's not with risk to do a vaginal examination. Of course, there's, other ways to see how a woman progresses. However, in hospital, depending on if you have a midwife there continuously or not, in many places they are running between different women laboring and birthing. Then all these tools of measuring and controlling you is a way of, well, controlling the situation when it's not a midwife just sitting in the room with you. If she's in the room with you, she noticed the difference in your sounds and the way you're acting and everything. But in hospital, a lot of the times midwives don't have time for that. And they also have the pressure to do all the measurements and do the documentation of everything. And of course, you can decline. Again, you can decline everything. And that is so important for you to know. There's no law that when you walk into hospital, you have to, do all the things they tell you. Not true. You can decline everything and anything. And then you can change your mind. So you can decline something and then go like in a few hours, oh, actually, now I want a vaginal examination. I want to know where I'm at. Now let's talk about breaking of waters. The only benefit of breaking your waters is that it could potentially, I mean, research does show though that this might not necessarily be true, but anecdotally and kind of the feeling one have is that it can speed things along. And that's why a lot of midwives or doctors might recommend that they break your waters artificially. Amniotomy, it's called, with a little hook. They go through the vagina and the cervix and hook the membranes and break them and release the water. Now, yeah, so this is something that might be offered because of, again, the factory mindset that you're taking too long. They need your room. They want you to birth in a certain amount of time, and they don't think that you're doing enough progress. Then they might suggest breaking your waters. And the only benefit is that if you want that. Now, what it does do, which is the risk then and the result of it, is that it doesn't go faster. It just becomes much more intense because the waters kind of cushion and spreads kind of the sensation of the contractions evenly. Whereas when the waters break, that cushioning doesn't happen anymore. Um, and most likely what happens too is that the head really applies even further down the vaginal canal, and just the intensity becomes much stronger. And this obviously also happens for your baby. So it can definitely affect the baby. There's a risk with breaking the waters that it stresses the baby. And I've already mentioned, that it increases the risk of infection and the need for pain relief because of the increased sensation of pain and intensity. It can also increase the risk of that when it happens not naturally, when it happens artificially with someone doing that with a hook, is that your baby's head has not had the natural way of applying its head perfectly and then breaking it on its own, which most babies do. Most babies will break the waters. Sometimes it happens as labors begin, but sometimes, most likely, it happens later on in active labor, closer to the birth, or even at birth. Then the head is really far down and it's applied most likely perfectly. Whereas when you break the waters before the head does that, the baby does that on its own, it might become asynclitic, or like, the baby's head is not applied perfectly. It's tilted, or, comes down in a not optimal way, which then increase maybe the length of that labor, the length of that pushing, potentially. Um, yeah, and this might also then increase the risk of instrumental birth or cesarean. So I am definitely not a fan of, if you want to have a natural birth, to meddle in any way, but to allow nature to take its course because it is the wisest way. And it's important to know that something that is so often offered in hospital, which is breaking of waters, actually has a lot of risks with it. Then let's talk about the CTG, so the continuous monitoring of a baby's heart rate and your contractions. This is quite common to do maybe at triage or as you get into the birth suite. Many places around the world do, however, if you are low risk, do intermittent auscultation, which is listening with a handheld Doppler for a minute to listen to the baby's heart rate, and then do that every 15 to half an hour throughout labor, and then do it every 5 minutes or after each contraction as you are pushing your baby out. That's usually what is done. But some places around the world, some countries and some hospitals and so on and so forth want to do a trace for 20 minutes as you come in labor to check out what's going on. Now, the ones who continue to do this on low risk women or on healthy women and their babies, it's very much criticized around the world because it's been shown that it increases the risk of intervention and medicalization of birth. It increases the risk of cesarean, instrumental birth, scalp electrode, other complications for the woman, and it really interferes with her freedom of movement and having an undisturbed birth space to move around in. So there really is no benefit, actually. It only increases the risk of everything. And I really want you to hear that. There's no benefit. Research has shown this over and over again. Actually, research has shown that even intermittent auscultation, even listening to baby at all in labor and birth, it doesn't change the outcomes. Some babies will come out and need some help. Most babies will not. But listening to the baby in labor actually doesn't affect the neonatal outcome of that baby. And I think that's really worth mentioning. It's confusing, especially to a midwife who's been taught otherwise, and kind of we rely on this technology so much in the world today to tell us if a baby is doing well or not. But at the end of the day, there's so much misinterpretation of the CTG, and it's just shown that it just increases all the medicalization without the benefit for the baby, which we are trying to protect through the CTG, through, listening in. So, especially when you're having a natural birth, there is zero benefit and only risk. want to repeat that. Zero benefit, only risk. Now, if you're having an epidural or a medicalized birth, we're talking a different scenario here. Yes, you want to have a CTG on to make sure that the baby's coping with the drugs. Different scenario. With a natural birth, however, no benefit. Anyway, let's talk about scalp electrode. This is just become the standard, especially where CTGs are used. It's almost always then used with the scalp electrode because if women want to be mobile and moving, that CTG is just not picking up the baby and the heart rate properly. And so then what is offered is a scalp electrode, which essentially is a little screw screwed into the top of your baby's head. Yes, it's not a little clip, it's a screw. They screw it in into the top of your baby's head. Oh, and it hurts me so much that this is so common. Almost all babies, I feel like, have a scalp electrode today, especially in those countries or places or hospitals that do continuous CTG for no good reason. It's almost 99% of women with the CTG will have a scalp electrode because, again, the CTG just won't pick up the heart rate continuously. Women move, women want to be in water, women want to, of course, move, especially if you want to have a natural birth. Like lying on your back is excruciating. So the benefit of a scalp electrode is that it picks up the accurate heart rate of the baby. But as I just told you, it actually doesn't increase the good outcomes for the baby. Again, it actually does the opposite. Monitoring of the heart rate only increases the risk of medical intervention. Oof, I think it's awful. Anyway, lots of risks, of course. I mean, for the mom, we've already talked about breaking of the waters, but the risk for the baby, of course, is, pain and stress for the baby, increased risk, obviously, of infection, and the risk of misplacing the electrode on both the mother instead of the baby, but also on other places of the baby skull where it shouldn't be. Anyways, there's no difference in outcomes with CTG readings with the scalp electrode compared to intermittent auscultation or nothing at all. So, yeah. I mean, with all of this that I'm sharing, there's so much research and evidence on this. So do your own research and look into all of these things and make informed decisions about your labor and birth and put it in your birth plan and have a birth worker that you've employed that's gonna advocate for you and protect your space. But because the coercion is very high in maternity, very, very high when you're in labor and birth. And when you are in labor and birth, you're so open and vulnerable. I mean, you're so powerful, but you're also vulnerable and the hormones make you agree to things. You're not yourself when you're birthing. Like you're definitely more impressionable about what's happening around you. So synthetic oxytocin is something that is used so much in hospitals. And if it's not used in your labor for augmentation to make things move quicker and so on and so forth, then it's going to be offered after the birth of your baby to prophylactically prevent a bleeding, a hemorrhage. Well, that's kind of how it's sold. Actually, what research shows, though, is that if you've had a natural birth of your baby, then the risk of bleeding after birth is higher if you take the synthetic oxytocin that is supposed to prevent it. So again, for low-risk woman and baby, there is no benefit of taking this prophylactic synthetic oxytocin after birth to birth the placenta. It's better to just wait and see if it's needed. If you start to bleed heavily, then you can take the medication that is meant to prevent bleeding or stop bleeding. So yeah, this is very interesting. The risk to use synthetic oxytocin may have an effect on postpartum mood disorders and can cause lactation difficulties in mothers and reduced ACAR scores and increased NICU admissions for baby. This is if it's used within labor. So that's deviating them from having a natural birth. You're taking drugs that is, doing something. But it's important to know this because it's used so heavily in hospitals. It's just taking as something safe to do to speed up labor. And also obviously after. It may also have a correlation with increased neurodevelopment risk in children. This has been suggested by some new studies. So it's just important to know about this because it might be offered to you in labor and birth. And with this, I want to say that labor and birth has no time limit, even if they want you to think that it does. Another thing that is very common in hospital is coached pushing. A midwife or a doctor telling you how and when to push. First of all, this happens a lot that vaginal examination is telling the midwife that, oh, you are 10 centimeters now, you can start pushing. But if you don't feel the urge, then it's not time. The head of the baby is too high. When the head of the baby drops low enough in your vaginal canal, which really helps with gravity, so being upright, being on all fours, moving, swaying, dancing, sitting on a birth ball, just naturally following your body's impulses because your body's going to tell you what's best for you and your baby and the birth process. When the head comes down low enough, it's going to feel like you involuntarily are vomiting with your vagina. No one needs to tell you that. Just go with your body. Follow your body. So, some women do want coaching. And if that is you, then it's a benefit for you. And if that gives you comfort and you feel like, you're getting the help you need, perfect. The risk is that you dissociate from yourself and you just listen to someone outside of yourself, the expert outside of yourself telling you how to do it, instead of listening to your innate wisdom and your body and allowing it to do its thing. Your baby and your body's going to birth your baby for you if you allow the force to come through you and you open and you breathe and you relax and open. And that's really hard. I mean, and that's why one of the things I recommend, which was in the previous solo episode with me about how to prepare for natural birth, is to do perineal massage, to learn how it feels when there's this burning sensation and how to learn how to relax and open and breathe in that. Because the risk of allowing someone else to coach you is that it's disempowering. It takes away your trust in yourself. And so I encourage you to follow your own body and if you want help, then ask for it. And you can state that in your birth plan that if I don't ask for it, then don't coach me. And if I ask for it, help me find my own and trust my own feeling before you tell me what to do. And then we have something even, I think, worse, which is vaginal coached pushing. And this is quite common as well, which is that usually here you're lying on your back or you're kind of semi-recumbent on the bed, and a midwife places her fingers inside of the vagina and pushes down to help guide you where to push. Now, yes, this can help, especially if there's an emergency and we need you to really get that baby out faster. Could be a good thing to potentially have that help. Or if you yourself feel like I've been pushing for hours and I want some guidance because I don't feel like I am finding the right way to push my baby out, potentially. There's no like this should never happen, but this should never happen on routine. the risk of this is just it's a violation. It's just a violation of your most intimate place within. It's a violation of your body. It's a violation of your trust to yourself. It's disempowering, can be distressing. This should only be done if asked by the woman, and in very rare circumstances, very, very rare circumstances. Otherwise, just follow your own instincts. You can push your own baby out. Trust yourself. Then we have another thing, which is perineal pressure at birth. Now, this is where the midwife either puts her hand or a warm compress. Now, the warm compress has good benefits. Um, Research say when it comes to reducing tearing, and it's when it's used in between pushing on the perineum, and it's not hard pressure, it's just put there, and in between when the baby's doing its little turtling coming out of the vagina, it's taken away. This is different from perineal pressure at birth, which essentially is that a midwife is putting her hand on the peri and on the head to slow down the birth of the baby's head. Now, this makes sense if you can't feel, if you're having an epidural, if you're on your back. But if you're not, then it can be very uncomfortable. And to prevent tearing, the better way of doing that is to follow your body, to end up on all fours. This is what a lot of women do. It's a good way to slow things down. Be in the water is another thing. The woman can herself, you can yourself hold the head and feel and ease it out, and touch where you feel. Some women feel instinctively to hold against their clitoris because it might be burning, or hold the head as it's coming out and hold around the vagina. If you naturally feel that, then you do that. But to have a midwife doing it, there's no good evidence that that actually decreases the risk of tearing. And so the risk is that it's uncomfortable and painful. The benefit is not known. And water birth and warm compress has much better evidence that actually shows that it lowers the risk of tearing. Righty. Coming to the end. Let's talk about the birth of the placenta. If you've had a natural birth of your baby, then you should opt in to have a natural birth of the placenta, which is opting out of the active third stage management, which is taking the synthetic oxytocin, which is just, increasing your risk of bleeding, increasing, what we're trying to prevent with it. So it doesn't make sense. Instead, just watch and observe and see if there is too much blood loss, then there's, you're in a hospital, they're going to be able to give you everything under the sun. So no need to be prophylactic here. If you follow evidence, it tells you not to. So just on a note there, if you for some reason do want to do this active third stage, what they do, and this is just general standard, if you have not opted for a natural physiological birth of the placenta, it's going to be assumed and done to you in many places, this active third stage, which is the synthetic oxytocin at birth. It's supposed to be given as the head is out, not even the full birth of the baby. You're supposed to get this injection, which is insane. But most likely it's given just after birth in your leg. And then you're given about 15 minutes, or should be given around that time, for the placenta to detach from the uterine wall, come down into the vagina, and then the care provider will hold kind of on your belly just above the pubic bone to kind of hold against, so that the whole uterus don't come out as it pulls, as the care provider pulls out the placenta manually, pulls on the cord. Should be done very gently. However, there's risk here. There's risk of pulling before the placenta has detached. A lot of practitioners are very impatient and they snap the cord, which is terrible, especially if the placenta is still attached. Then the pulsation of the blood just continuously pulsates. The baby obviously doesn't get that blood. And also there's, risk with that with the placenta being in there and potentially having to rush you to theater. I mean, yeah, that's one of the risks. Um, and obviously doing this also means that they cut and clamp the cord pretty quickly, usually. I mean, there's definitely the alternative that you're given the injection, they pull on the placenta and let it come out without clamping the cord. So there's two different options there, but usually that is how they do it. They clamp and cut the cord, they pull in the cord, they pull out the placenta. Again, this is all to prevent bleeding. The option is that you just birth it yourself, which if you want to have a natural birth, you most likely want it to do. And there's options. You don't cut and clamp the cord, you let it be intact. You can choose to do it hours after birth. You can choose to do it straight as it comes out. You can do it days after, or you can even do a lotus birth, which is just keeping it intact. And that's a different story. Oh, here's a really important one, which is so common nowadays, and that is taking cord bloods. Ugh. It's not cord blood, it's the baby's blood. It's done straight after birth of the baby, sometimes even before the placenta comes out, where a midwife or a nurse will take blood, so prick the umbilical cord and take cord bloods from the baby to analyze for essentially statistics. That is essentially what they're doing. Checking, the gases in that cord blood to see for the statistics. They say it can pick up, if a baby has been distressed in the labor and birth process, but you can see that on a baby when it's birthed, and you can act on it after birth if it's needed. You don't need to take the cord bloods for that. And then there's a lot of parents that nowadays have been sold the idea of then keeping cord bloods for stem cells for later if the baby gets sick. This is depriving your baby potentially of a third of its blood. When it's pricked, especially when it's pulsating, that's going to bleed through those holes. So choosing that could mean that over a third of your baby's blood might not go to your baby, and your baby needs that at birth for the whole transition to life. I mean, that process in itself I could talk about for an hour or more. So benefit for a normal natural physiological birth, none. Risk, the baby is deprived of its blood as it leaks from the place that it's taken. And the alternative is to just not take the baby's blood. Or you can do it from the placenta later, which, still contains blood after birth if you want to do it, not at birth. Let the baby get the blood through first until the cord starts going more white, and you can take it from the placenta. It is a routine procedure that's happening everywhere. So this is something you have to research and take an informed choice around if you want to do. Which, if you're not doing stem cells banking, which I'm very, I question, then really don't do it, because it's just for statistics, really. And yeah, we have delayed cord clamping. I think if you're all about natural birth, you know about that. Delayed cord clamping, there's only benefits, there's no risk. There's this silly idea that if you don't clamp and cut the cord, that somehow the blood in the baby will go back into the placenta, which is just an insane idea. It goes against all logic and evidence, and it's not true. So wait for white. Just allow the cord, whether or not you want to cut it before the placenta is out or not, to be fully white and floppy. There's no blood coming through to the baby. That's when you know that the baby has gotten all of its blood, because it is the baby's blood. Obviously, we want to do skin to skin. Always, 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 never, ever take a baby off a mama's chest. Still, places around the world do this because they want to wash the baby, they want to swaddle the baby, they want to put a hat on the baby. No, 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 no. Just no. Not for hours. Not necessary. Just keep the baby on the mama's skin. I mean, it's just the benefits are enormous and endless. Having the baby on your skin regulates the baby's temperature, heart rate. It helps the baby transition. It helps the baby get regular breathing patterns. It gives the baby warmth and safety. Of course, it's super important to initiate breastfeeding. You can see the baby do baby crawl and attach itself to your nipple. I mean, it's endless. It regulates the baby's sugars. It just regulates the baby on all levels. For all babies, low risk, high risk, every risk, babies should always be skin to skin with the baby or with the mother. The mother is the best for regulating that baby. No one else, not even the father. Father is second best, partner is second best. Mama, magic happens. Magic happens. Just, yeah. And then, after the birth, we have all the things that happen. So we have the inspection of the perineum to check for tearing. This can be done later. You don't have to do this. You don't have to do it, period. You can say no to this. If you want to do it, the benefit is, of course, discovering if you have more than a first or second degree tear. A first degree and even a second degree tear can actually heal well together. A practitioner can see if it's a kind of clean and sense straight tear, then and it comes back together really nicely. Then as long as you keep your legs together, especially for the first week, and rest for a month really, then it can heal really beautifully on its own. If it's not coming back together perfectly, if there's, yeah, a practitioner can see the level of tear, even if it's a second, and it might benefit from a stitch, then that could be something that you want to opt for. There is really no rush with this. Just have your golden hour with your baby or longer. It's no rush. The same with the baby check. The baby check is measuring your baby's head and length and weighing the baby. It's also going through kind of from head to toe. Usually a midwife, or in some countries it's the pediatrician. They just check kind of everything that, baby has everything, all the toes and the fingers and the ears and the mouth and the, open anus. They check just, we just check through the whole baby's body to see that it all looks normal and has normal reflexes and everything. It kind of can pick up if something's deviating to explore that. So at this time, though, first of all, it should not happen the first hour, preferably hours after birth. Just have your baby skin to skin. The check can be done on mother. In hospital, it usually is done on the resus table under kind of a heating lamp. Um, you know, this is also the time where they will be offered in all countries vitamin K injection, and also in most countries around the world now, hepatitis B injection. Now, oof, there's so much to talk about this, and I will just briefly mention how you should think about this. Now, first of all, there's no rush to take either of these injections. Vitamin K is a vitamin, and it's synthetic, however, and it's a big dose. It's put into the baby's leg, into the muscle, and it's thought to release slowly for the next 6 months as your baby's born with low vitamin K, and breast milk gives baby low vitamin K. And nature has designed it that way. We don't know why, but nature has, possibly to make the blood flow very easily into the cells and around the body of the baby as it's been birthed. If there is trauma, the blood with the stem cells that some want to collect for later, well, that will go in and heal the baby. And vitamin K makes the blood just more, it doesn't clot as well as it does with strong vitamin K. So that's why it's given, because very few, but some babies are born with well, it's called different things, but hemorrhagic disease of the newborn is what I was taught that it was called. And that means that some babies will, for some reason we don't know, be more prone to bleeding and then not clotting their blood effectively to stop that bleeding. And a few babies will have this, and the vitamin K shot will prevent this from being deadly to very, 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 very few babies. But those babies are, at high risk. And so There's also some evidence that you can have some risk factors that increases the risk for you to have a baby with this. So I encourage you to do your research around this. If you are a high risk person that might have, this kind of baby, then maybe this is something you want to opt for at birth. And if you don't, then maybe you want to do more research and see what's right and wrong for you. It's definitely a benefit that it has definitely saved a lot of babies since it started to be given, but we also don't really know what the consequences are, and why nature did this, that babies, have this low vitamin K when they're birthed. You can read more about this in my book, in my little booklet. Now, hepatitis B is a vaccination, and it's given literally within just the first few hours after birth in most countries. Not in Sweden, where I am currently, and not in all countries, but in most around the world. To give a hepatitis B vaccination at birth has been routine worldwide since 1991. Hep B is a viral infection spread by blood and bodily fluids. High-risk groups are illegal IV drug users, prostitutes, or having multiple sexual partners without using protection, as well as receivers of blood transfusions. So what's the benefit? The benefit of hepatitis B vaccination would be if you are a part of a high-risk population or live amongst them and will expose your baby close to after birth to this environment or community where it could be exposed to blood or bodily fluids of someone with hepatitis B. And the risk, obviously, is that no drug or vaccination is completely safe. I mean, that's just the reality of life. Nothing, even water, is completely safe. You can drown yourself with drinking too much water. And so, obviously, the biggest risk is anaphylactic shock, which is rare but happens. And I really encourage you to do your due diligence on all the vaccinations, and the risks with them, when you decide which ones you want to do for your baby or not. The alternative to not do this at birth is to do it with the schedule or just anytime later on in life. If there is a risk, either that your baby is going to be in a high risk community, be exposed by this. So that's the alternatives. Yeah. Hepatitis B at birth is something that I question heavily. And I think it is wise to do so too. If you're not a carrier of hepatitis B, which is a totally different scenario, or your partner or your immediate family, or people you hang out with, that they have it and they are going to be exposed to your baby's going to be exposed to them in the first weeks after birth or first months or whatever before, or if you ever decide to give your child this vaccination, I really don't see how this is beneficial to your baby hours after birth. Then we have the mother check, which is, checking your blood pressure, pulse, temperature, checking your fundus. I want to speak to this because especially in hospital, first of all, these observations happens literally maybe minutes after birth and then every 15 minutes in some places. You can opt out of this, obviously, as with everything. But especially around the world, I hear about this horrible fundal massage that people are being exposed to. And fundal massage is great if you're heavily bleeding, if you're having a postpartum hemorrhage. You want someone to be on your tummy and rubbing that like crazy. You want that to happen. But if you're not, then no one should do that. Then actually it would be increasing the risk of bleeding if you're causing pain and discomfort to the mama. So I've been a midwife. I know you can very gently feel the fundus and know if it's well contracted or not. You don't have to do that very heavily and harshly. You can do it very gently. And you can do it yourself. As a mama, You just put in your hand straight in where your belly button is, and you press a little bit down, and you feel if your womb is contracted, which it does. It's incredible how it kind of draws back down to 50% size within minutes after birth. It kind of will feel like a very hard, firm tennis ball around your umbilicus, around your navel point. I mean, so you can do that on your own, feel that and have that power to know yourself. Or if someone's doing it for you, then they don't have to do it harshly and ask them not to, and otherwise tell them to step away. Like you can, or your advocate can advocate for you, your birth worker. Yes, and then we have early discharge. So if you've had a natural birth in hospital, then you can discharge like 4 to 6 hours after birth when you and your baby, have had time to bond and established breastfeeding, and you've had maybe your shower and had something to eat and feel well, and your baby's well, then you can go home, which is great, which is perfect. Because the risk is if you stay in the hospital in the postpartum ward is that you get heavily disturbed. That's the fact in a hospital. As long as you're in the hospital, they're going to want to do at least once a shift. They're going to want to do observations on you and your baby. And that will happen during the night as well. I mean, that's just how it is. When there's a shift change, they want to come in. They're going to want to come in during their shift to check you out. Um, and if that doesn't happen, if there's someone that is really good, especially during the night, to not disturb you, then you're going to hear people in the corridor and other babies and stuff going on. And you're going to be exposed to during your stay there different midwives and nurses with different opinions about how to breastfeed or formula feed or this and that. And you're going to get 100 million different advice. And some might be good, but it might also be really confusing. And so this is just really something I've very much observed, both as a midwife in the hospital, but also with clients who might want to have that stay in the hospital because they feel more safe doing that for the first 24 hours or 48 hours. But it again, the longer you stay in hospital, the higher the risk of interventions and pathologization happens. It's actually just how it is. Another reason that you might not want to stay is that you are exposing your baby not to your home environment to inform their immunity, but to the hospital environment with disinfectants and cleaning products and antibiotics in the air. That's also a reason that you might consider going home earlier after birth. So that was, I mean, there's so much more I could say about things that are done in the hospital, but that's kind of a bit of an idea. Now, I haven't said everything in my ebook, so please download it and read it thoroughly and do your own research. Obviously, nothing that I'm sharing is medical advice. And yes, I do have some opinions here and there that are personal and not, something you should take as law or anything like that. Or, always do your own research. Definitely don't take anything I say as gospel. Don't take anything anyone says as gospel. If someone says they know the truth, then run. um, and this, I hope, have given you kind of an idea what it looks like to birth in the hospital and the things you need to take decisions about before. And this is just having a natural birth. This is just having a normal natural birth in hospital. Now, had you opted in for, and obviously you're not because you're listening to this, but if there's any kind of medicalization, then there's even more stuff, obviously, that's going to go down. And that's when it's so good to have a sacred birth worker or a doula that you really knows her shit and has a strong throat chakra that can be this anchor for you, that can be the advocate for you. Because just as you're researching midwives, obstetricians, hospitals, you want to research doulas or sacred birth workers. I'm so proud that I have more and more of these beautiful sacred birth workers of mine out there in the world supporting women who really know so much because of their thorough education with me. You want someone who really has all of that and who knows her shit so that she can be that birth advocate for you, because there's a lot of doulas out there, and this is not doula bashing because I love doulas, but there's a lot of doulas that have maybe a weekend course under their belt and knows maybe as much as you if you've done a birth course about the birth process, and there's some great doula trainings out there, but I truly don't feel like they are as thorough as they should be. Most doula trainings are very, much, especially if they're kind of DONA certified or certified against some sort of body, are very much teaching you not to step out of your scope of practice, which essentially means do not argue or, confront doctors and midwives about the policies and guidelines. Step away. It's not your business. It is her business. It should be her business to know them and to be able to argue against all the unevidence-based ones and protect you in that system. Really. So if you choose a doula, know that if she is certified, she might not be the advocate that you want and need in that system. That is why my sacred birth workers, I do not provide a certification towards some sort of international body or national body, because I don't believe in that. I actually think that that prevents them from being the kick-ass birth rebel advocates that actually women need today. And so if you're, wanting a sacred birth worker, you can reach out to me and I can maybe potentially provide you with one in your area. I have, beautiful women all over the world right now who's taken my sacred birth worker mentorship and has taken it, who are already graduated. And so I can point you in the right direction. And if not a sacred birth worker, choose someone that doesn't have an allegiance towards someone who has certified her, or that she doesn't have, if she's, if her throat chakra is blocked or she hasn't worked on herself, if she, like most of us women, to be honest, have, maybe problems speaking up to authority, then maybe she will be a deer in headlights in that hospital setting, when you actually need a kick-ass advocate. So be very thorough in finding the right birth worker for you, but find one. Do not have a hospital birth without someone there to support you who knows their shit, who knows about physiology, who knows about the hospital system, who knows about how to advocate for you, who knows about patient law and human rights. This is important. My graduates knows all about this and are kick-ass advocates for women. Kick-ass. So I hope that this episode has been helpful. And of course, if you want any more support, then please reach out. We can work together. I work with women all over the world online through one-on-one sessions, and obviously have the natural birth course and the nourishing postpartum course for anyone who wants to dive deeper into learning about the processes and how to support themselves to have a natural birth and a nourishing postpartum for themselves and their babies, of course. Thank you for listening, and I'll see you next time. Thank you for listening. If you love this podcast, then please consider sharing it, leave a review, or make a contribution on our Patreon page. And if you want to connect on social media, then find the podcast on Instagram as The Natural Birth Podcast. Thank you for listening.